Hey everyone, and welcome to this explainer. Today, we are absolutely decoding the mechanics of diabetes medications. Whether you're a nursing officer, a med student, or just someone who is intensely curious about clinical pharmacology, you are in the right place. We are going to break down this massive, sometimes overwhelming topic into a highly structured, practical toolkit. We're going to take all those raw physiological concepts and translate them straight into everyday clinical practice. Okay, let's dive into this. Our roadmap for the explainer is pretty straightforward. 1. The core glucose problem. 2. The pharmacological toolkit. 3. A deep dive into insulin therapy. 4. Safe insulin administration. And finally, 5. Crucial nursing implications. If you look at a diabetic patient's chart, it often reads a bit like a pharmacy inventory, right? It's huge. Which really begs the question, why in the world do we use so many different drugs for one single disease? Well, the answer is that the human body isn't just a simple machine. It is a highly complex factory. And when glucose regulation breaks down, it's not just one little gear failing. We are talking about a systemic breakdown across the intestines, the pancreas, the liver, the kidneys, and even the cells themselves. To actually fix it, we need interventions at multiple, highly specific points on that factory assembly line. So let's start with section 1, the core glucose problem. We really need to understand where this factory breakdown actually happens. Think of this as a beautiful physiological chain reaction. When you eat complex carbohydrates, they travel down to your intestine. Step 1, an enzyme called alpha-glucosidase breaks those complex carbs down into simple glucose. Step 2, as that simple glucose enters the intestinal lining, your body releases a short-acting peptide called GLP-1. This is essentially the messenger. It rushes straight to the beta cells in your pancreas, sounds the alarm, and triggers the release of insulin. Step 3, that insulin travels to your body's cells and basically acts as a key, pushing these GLUT4 receptors to the cell surface. Those receptors then literally grab the glucose out of the blood and pull it inside to be used for energy. That's your body's natural built-in system for preventing a massive blood sugar spike right after a meal. Now, how we go about treating the breakdown of this system depends entirely on the type of diabetes we're dealing with. For type 1 diabetes, where the factory has essentially just stopped producing insulin altogether, we really only have two options. We either replace the insulin, or we use pramlintide, which mimics a naturally co-secreted hormone. But for type 2 diabetes, this is where the factory is still technically working, but it's heavily resistant or super inefficient. In that case, we have an entire, massive pharmacological toolkit at our disposal. Which brings us to section 2, the pharmacological toolkit. It is time to fix that assembly line. And this brilliantly illustrates our main cheat sheet of interventions. Let's walk through it. First up, biguanides, like metformin. See, when you're fasting, your liver naturally produces glucose. Metformin comes in and basically tells the liver to stop overproducing. Pretty simple. Next, SGLT2 inhibitors, like empagliflozin. Normally, your kidneys filter and reabsorb glucose, while these drugs block that reabsorption entirely, forcing your body to literally pee out the excess sugar. Then, we have sulfonylureas, like glimepiride. These drugs forcefully squeeze the pancreas to make it release more insulin. And finally, GLP-1 agonists, like semaglutide. These act just like that natural GLP-1 messenger we talked about earlier. They delay stomach emptying and ramp up insulin release. Now, here is a pro tip. Instead of rote memorizing a huge list of side effects, just use cause and effect chaining based on the mechanisms we just went over. It makes total sense. Think about it. If SGLT2 inhibitors force glucose into the urine, what's going to happen? Bacteria and fungi are going to feed on that sugar, causing UTIs and yeast infections, right? Plus, the sodium loss causes dehydration. If GLP-1 agonists delay stomach emptying, food just sits there longer. That means you feel full, leading to weight loss and, naturally, some nausea. If sulfonylureas artificially force your pancreas to release insulin regardless of your actual glucose levels, you run a massive risk of dropping blood sugar way too low, hypoglycemia, along with potential weight gain. And if you use alpha-glucosidase blockers to stop the digestion of carbs in the intestine, well, those undigested carbs travel down to the colon where bacteria ferment them, causing, well, let's just say, massive flatulence and diarrhea. It's all just logical consequence. Okay. But listen up, because here are the absolute red flags you must know for clinical safety. These are crucial. Metformin is strictly contraindicated in patients with renal or liver failure. Why? Because it carries a very real risk of fatal lactic acidosis. Pioglitazone, which is a drug that reduces insulin resistance, dangerously retains sodium in water, which can lead to severe edema and potentially congestive heart failure. And DPP-4 inhibitors, which stop the breakdown of natural GLP-1, require major caution in renal failure. There is only one exception to that rule, and that's linagliptin. Let's shift gears to section 3,
a deep dive into insulin therapy. This is the ultimate glucose manager. Over the decades, science has literally engineered insulin to mimic our body's natural rhythms, giving us a whole spectrum of durations. At one end, we have ultra-short-acting, like Afrezza. This is actually an inhaled powder that goes to work almost instantly. Next, we have short-acting regular insulin, usually given right before meals. Then, by adding elements like protamine, scientists created intermediate-acting NPH, which famously has a cloudy appearance. Moving further along, we've actually genetically altered the amino acid chains to create long-acting baseline insulins, like glargine and detamir. And finally, the absolute cutting-edge, ultra-long-acting icodec, which is so advanced it's administered just once a week. Truly mind-blowing.
Now, to understand why a patient might be prescribed multiple different types of insulin from that timeline, we have to define our two main treatment goals. First is PPH, or postprandial hyperglycemia. That is the violent, sudden spike in blood sugar you get right after eating. How do you tackle a spike? With a spike, meaning you use those short and ultra-short-acting insulins. Maintenance, on the other hand, is about the slow, steady release of glucose from the liver all day long. You tackle that constant baseline with your long-acting insulins.
And understanding that distinction actually busts a massive clinical myth. A lot of people assume that because long-acting insulin stays in the body the longest, it obviously poses the highest risk for crashing your blood sugar. Actually, scratch that. It's completely false. Short-acting insulins create a massive, sharp spike in plasma concentration to fight food intake. If the patient doesn't eat enough food to match that spike, boom, severe hypoglycemia. Long-acting insulins, though, they just maintain a low, flat plateau, which makes their hypoglycemia risk remarkably low by comparison.
Which leads us right into Section 4, safe insulin administration. Let's talk about the actual protocols for practice.
How you physically handle these drugs is absolutely critical, especially when you're mixing them in a single syringe so your patient doesn't have to endure multiple needle sticks. The golden procedural rule here, clear before cloudy. Step 1, you always draw the clear, regular insulin into the syringe first. Step 2, you draw the cloudy, NPH insulin second. Why that specific order? Because if you accidentally push even a tiny, microscopic bit of the cloudy NPH into the regular insulin vial, you completely contaminate the rapid-acting properties of that entire vial. You basically destroy its clinical predictability. And hey, where you inject matters just as much as what you inject. Subcutaneous injection sites are definitely not created equal. They actually rank by absorption speed. The abdomen is the absolute fastest and most reliable site you can use. You just have to make sure to avoid the immediate area around the belly button. If the abdomen isn't viable for some reason, you move to the anterior thigh, followed by the upper buttocks, and lastly, the upper arm. Now, what's really fascinating here is a glaring exception to those absorption rules we just talked about. Glargine, that long-acting insulin, is highly unique. Its absorption rate is totally identical whether you inject it in the abdomen or the arm. It literally doesn't matter. But because of its highly acidic pH, if you ever try to mix glargine with another insulin in the exact same syringe, it instantly precipitates. It forms these completely unusable white crystals, so the rule is never, ever mix glargine.
Finally, we arrive at Section 5, crucial nursing implications. Let's bring all this pharmacology right back to the patient's bedside.
Let's do a rapid-fire rundown of actionable implications based on the mechanics we've covered today. Alpha-glucosidase inhibitors. We know they block carb digestion, right? So they must be taken quite literally between bites of food. Giving them after a meal is completely useless. For patients on metformin, you've got to monitor their vitamin B12 levels closely because the drug decreases absorption. For the wildly popular semaglutide, because it causes such rapid weight loss, you must ensure the patient is on a high-protein diet to prevent severe muscle wasting. And if your patient uses those Afrezza inhalers, memorize the cartridge colors. Blue is 4 units, green is 8, yellow is 12, and they are inhaled just seconds before eating.
Physical handling is also a huge part of the job. You absolutely must always roll suspension insulins, like NPH or Mixtard, about 10 times. Because they are suspensions, the active ingredient literally settles down at the bottom. If you don't gently roll that pen or vial to mix it up, you are just going to inject the clear liquid sitting on top, vastly underdosing your patient. On the flip side, you never roll clear, purely liquid solutions like deglutic. Let's also talk about lipodystrophy. It's one of the most common physical complications of daily insulin use. It's the hardening or destruction of subcutaneous fat tissue, and it completely ruins drug absorption. How do you prevent it? By strictly enforcing site rotation.
Even if a patient absolutely loves injecting in their abdomen, they have to map out different spots. And if they require 2 injections at the same time, you've got to ensure there's at least a strict 1-inch distance between the 2 injection sites. No exceptions.
And before we finish up, here is an absolute emergency room imperative. While almost all insulins are given subcutaneously, regular insulin holds the #1 spot as the only insulin administered via IV for critical emergencies. Whether you're treating the severe, life-threatening acid buildup of diabetic ketoacidosis, or you need to rapidly drive dangerous levels of potassium out of the blood and back into the cells during hyperkalemia, IV regular insulin is your undisputed drug of choice.
As we wrap up this explainer, I really want to leave you with this thought. By mastering this pharmacological toolkit, by knowing exactly when to use an SGLT2 inhibitor versus a GLP-1 agonist, or precisely timing a regular insulin spike to match a meal while glargine holds the baseline, are we merely lowering a number on a blood sugar monitor? Or are we, as clinicians, acting as physiological engineers, artificially reconstructing the body's perfect internal timing? I'd argue it's the latter. When you view these drugs not just as a boring list to memorize, but as incredibly precise tools to rebuild a broken factory, you totally elevate the standard of patient care. Thank you so much for joining me today, and keep learning.